So a common question I get asked all the time now as patients are becoming more savvy and doing more research is what approach I use for the hip. Not long ago, most patients wouldn't have a clue which approach. Now they specifically ask for a certain approach for one reason or the other. And currently I do a posterior approach, or the common posterior approach, and not an anterior approach. And I'll go over a couple reasons why I do that and why I don't think it makes much of a difference. A lot of patients are getting advertising or marketing about the anterior approach because it's been told that it's a miracle approach or that it changes the game. It's a game changer, let's say. There's no dislocation risk, you can do what you want, you don't cut muscles, and it's a minimally invasive approach. And part of this certainly is true, but for the vast majority of cases, the muscle is cut and split, the capsule is cut and split, and there's an equal risk of dislocation whether you go from an anterior approach or a posterior approach. The downside of the anterior approach is that you don't have as much visualization in case something goes wrong. And in case something goes wrong, you have to change the position of the patient on the table or move the patient so you can actually take care of any sort of situations. So in my view, in my way of thinking, it's better to do an approach which has equal risks where you can basically take care of any situation that you need to.